Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could answer during the broadcast portion of our show, so let's get started answering the rest of those. One viewer states, I used to be taking a statin and my LDL is down now. When I was taking it, my legs ached so bad. Did the doctors think there is a possibility that a statin can cause these leg aches? I have a pacemaker and artery problems. What do they suggest I do instead?
The statins have been associated with leg aches or muscle discomfort. Also, people get leg aches, muscle discomfort without statins. So in studies, people that are on placebo sometimes get muscle aching, and on the statin they don't, and sometimes vice versa. But there does seem to be an association. Sometimes a different statin might be helpful, sometimes coming off of it, going back on, or a different statin may be helpful, sometimes a lower dose, or intermittent dosing of the statin can be helpful too. But it is important to take the statin or do something to keep the LDL as low as possible to lower the risk for heart disease. Yeah,
I think most of my patients, if they have a really good reason to be on a statin, will usually try a different one or a lower dose, or you're right, trial and error, because sometimes it might have just been a coincidence that they had the leg aches at the wrong time. So, okay. A man from Sioux Falls asks, what is the optimum dose of metoprolol?
It depends on what you're taking the metoprolol for. Again, it's like if it's for atrial fibrillation, it's whatever the dose is that gets your heart rate to the desired range. There's obviously a maximum dose you could take. So
yeah, so it depends on how much they tolerate too. A man from Corsica asks, how far away timeline until they have a no-lead ventricular pacemaker? It's asking about new technology.
Say that one more time. So how long until?
How far away until they have a no-lead ventricular pacemaker? So we can show some of your.
So yeah, that's what this is. This already exists. This is the entire pacemaker. There are no wires. This just gets implanted into the heart. Has a little pod. So yeah, it already exists. The question is how long until we get a dual chamber, no-lead pacemaker. I've seen some ideas about how that could work, but nothing has made its way to any sort of trial yet.
Yeah. What are the big advantages to that small device compared to the other pacemakers that are more traditional?
Yeah.
Is there less infection risk with those?
Well, so if you don't have a device in a pocket, they can't get a pocket infection. You can't have a lead dislodgement. Those would be the big ones. The disadvantages or the challenges with these are that, again, you just have a one-chamber pacemaker, and a lot of times we're wanting to have information on both the upper and lower chambers. The other thing is that right now, when the battery depletes in this device, you just put a new one in. You don't. Whereas this, we would take the device out, put a new one in, and plug it into your leads. So you'd still just have the same amount of equipment in. Whereas here, you can, if you were going to live for a long time, you could accumulate several of these. The batteries last for about 10 years.
Yeah. And what is the typical battery life on a pacemaker or a defibrillator?
Pacemaker, 8 to 10 years. Defibrillator, some of them can be out to, I've seen 11, 12 years. If it's a biventricular device where you're pacing all the time, again, I've seen them typically 7 or 8 years. Depends a little bit on exactly what the thresholds are and all that stuff, but generally in those range.
All right. A man from Interior states, I have an irregular heartbeat. I have had it since I was young. Recently at night, my heart seems to beat really fast at a weird rhythm. If I sit up, I feel blood rush back to my extremities. Should I be concerned? It only bothers me at night, not during the day.
A lot of people can have irregular rhythms that are not at all risky. So most likely it's not serious. I think it's important to have it evaluated though, because there is a chance that it could be something, it could be atrial fibrillation or it could be premature ventricular beats, some things that can be associated with a risk. Why would it be at night more than day? Sometimes people, when they have abnormal rhythms, they feel them more when they're at rest or during the night. When they're up and active during the day, they just don't notice them more. So that's not an uncommon description. So I think it's probably important to have it evaluated. One of these heart monitors you mentioned, a 24, 48 or 2-week or even a 30-day monitor to see what the rhythm is and then decide is it appropriate to treat it further.
Yeah, with all these palpitations problems, we really just can't answer. We got to know what the rhythm is, right?
Yep, yeah. We record the rhythm when you're having the symptom. Yeah.
All right, a Watertown man says, I've had an ablation to control my heart rhythm and it didn't take. How many procedures can a person have for it, and could I do it again?
The answer is yes, probably for atrial fibrillation. Or maybe for PVCs. It's hard to know, but there's a success and a failure rate for all ablation procedures. Some are very high, 90, 95%. Others can be, 60, 65% likelihood that you completely eliminate the arrhythmia. There's really no limit, but after some people, I saw one physician who'd done like 5 ablations on someone and they still had the recurrence. It's like, well, after about the third one, you're thinking, maybe try something different.
Yeah.
At least have a different strategy.
Right. But it's not out of the question that he could possibly have a repeat procedure if he has a good reason to. A Sioux Falls man is wondering, is there a danger of taking rosuvastatin 10 milligram tablets, a day, causing damage to your liver?
Liver damage is extremely rare
Yeah.
with the statins. They used to advise checking the liver tests regularly. They've taken that out of the recommendations because the risk seems to be so low. There is a slight risk for diabetes with some of the statins, but overall, the degree that they reduce the risk for artery blockages or strokes or heart attacks or fatal events is far outweighed by this slight chance for diabetes. So the risk is extremely small for that much rosuvastatin.
Yeah, but that historical liver risk is extremely low. A Waubay man would like to thank Dr. Olson, as he says, I had a procedure done by Dr. Olson and it went well, and I am happy with how it went, so I just wanted to let him know.
You're very welcome. I'm glad it helped.
Another viewer states, I went to the doctor with some very severe back pain and had an EKG performed because they found troponin in the bloodstream. The EKG didn't find anything wrong. Echo was performed and the doctor said that was good too. Can troponin be produced by the heart when there is severe back pain? Or I guess the question is, why was his troponin elevated with those normal evaluations?
Troponin, it comes from the heart. There's a lot of reasons. There's a whole list of reasons as to why troponin can be elevated. The EKG doesn't necessarily tell you why it's elevated. There are people that have elevated troponin all the time, people with kidney problems and so on and so forth. So it's hard to really answer that question specifically, but yeah, the EKG doesn't necessarily always tell you why, and you can have a normal looking echo.
Yeah.
You could have a normal looking echo and have elevated troponin and a normal EKG and have an artery blockage that's significant enough to cause a troponin elevation.
Yeah. Viewer states, I was a chronic alcoholic for years, but I have not drank for 3 years. I got AFib a year ago. My mitral valve does show regurgitation. Can that be operated on later, or is this just old age catching up with me? I have had to have my heart shocked twice. So he's alluding to valvular maybe association with his rhythm problem, and is that a reason to have a valve surgery?
I think the atrial fibrillation itself is not a reason to have a valve surgery, but if you have severe mitral regurgitation and you're having symptoms from that, then you should have the valve operated on. Now, when they're operating on the valve, they should be thinking ahead when they deal with the atrial fibrillation. Hopefully they'll clip the appendage, the left atrial appendage, when they're doing the valve surgery. We even have, our surgeons will do some ablation. It's called a maze procedure type of thing that can also help with the arrhythmia. I found that if people have significant mitral valve problems, it becomes very difficult to keep them to control their rhythm, their atrial fibrillation.
Sure. That was the last of our questions. Thanks again to you guys. Was there anything that you brought that we didn't get to showcase here? Kind of showed the size of everything.
Yeah.
Okay, good. Great. Thanks for all your questions. We'd really appreciate them, and we appreciate the opportunity to answer them after hours. Until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.